Welcome back to the Pastore podcast. It is now the beginning of May, and May is also Celiac Disease Awareness Month. So we figured, why not put together a podcast? It is the perfect time to summarize a lot of the stuff that we talked about in previous episodes, but also introduce some new information. So if you are a previous listener to any of our episodes, this will kind of be a refresher or a rejig. And the more that you listen to it, I find the more you're able to understand it. So hang around, there's some cool information coming. So to start, Dr. Pastore, I would first love to know why celiac disease and why celiac awareness is so near and dear to your heart for those who don't know your story.
Yeah, I have, thanks, Lexi. I have celiac disease. I was diagnosed just a little over the age of 20, around 20 years of age. And I suffered for a very long period of time with different types of health abnormalities that no one could identify. And it was incredible that they were all connected to this one food-based disease. It completely changed my life, obviously, from a nutritional perspective, but it put me on this this thirst and this quest to learn everything I possibly could about this disease. And it has not stopped being an obsession all that time. So it's been basically my mission in life to do everything I can to help people get diagnosed. I was born with this disease. I'm a double genetic carrier. We'll talk a little bit about the genes today, and my daughter has those genes as well. Thankfully, I'm very aware of it. My parents were not. And what transpired in me was basically on and off 20 years of being sick before getting a diagnosis, everything from seizures and cardiovascular abnormalities and arrhythmias and atrial fibrillation, which is a type of an arrhythmia of the upper chamber of the heart, like really not fun stuff, lots of medications. Long story short, it really was this disease. So when I started digging deep, I started discovering researchers that shared my frustration. The average time to diagnosis was around 10 years, and I doubled that in my case. But my main excitement about why this month is so important, and I love that it also is the same month of my birth. So that's like, I guess I was just meant to be a celiac disease researcher by default, is the following. I kind of boil it down to four key things, Lexi. One, there was this paper that blew my mind, and it's still real and it's still accurate. It came out by a researcher team led by Rubio Tapia. So Rubio, Tapia, and colleagues were the first to look at like just under 10,000 cases and then repeated the research of individuals and identified that there's about 83% of individuals with celiac disease walking around the planet right now that are not diagnosed.
So if you have a room of 100 people, 83 are struggling silently, suffering, undiagnosed. And then the other, 17 are diagnosed.
Yeah, and that's a scary statistic. So that number one rule I've had, and it's always been my driving force, pushing this to get doctors to become educated, is just the short sentence, celiac disease is underdiagnosed. That's the term. Why? I don't know. Back in my day, it just didn't seem like it was more of a common thought in the mind of a primary care physician, no less a gastroenterologist, but my symptoms weren't primarily gastrointestinal until much later in the course of my illness, which is very common, and we talk about that all the time, that many people don't even present with gastrointestinal abnormalities. I mean, a flag should have went off when I showed up and had 16 cavities diagnosed by a dentist in one visit after having a visit the year prior and really taking care of my teeth. Clearly there was something wrong, but no one connected the dots, and my life has been connecting the dots. The second out of the four reasons why I'm so excited about this month and the awareness factor is that celiac disease is strongly linked to other diseases. So it's not only linked to diabetes, and we have all these race for a cure. And just to give you some perspective, the incidence of diabetes is like 1 out of 500, and I am not down implied diabetes. It's a terrible disease. It needs to be cured, et cetera, et cetera. I work with a lot of diabetic patients, but keep in mind, celiac disease, the prevalence is like 1 out of 100.
So right now.
Yeah, right now, exactly. Right now, where doctors are finally, when they catch it. And by the way, that's been my whole academic and professional career. It's been 1 out of 100. And that math doesn't seem to work out because I know I have a tainted pool, but I found a lot of cases in my career that otherwise would have went under the radar. So linked to other diseases, diabetes just being one, autoimmune diseases, we're always learning about a new disease that can be traced back. I started becoming obsessed with diseases that would transpire on an abnormality of chromosome 16. That covers all neurodegenerative diseases, certain types of cancers. I was able to find a correlation between my late father's prostate cancer and more than likely undiagnosed celiac disease, which is probably where I got it, definitely, even though it can skip a generation. So that's a very important thing. People could be following a pathway of treatment for a disease, and the main cause could actually be celiac disease. So that's another strong importance. The third is the fact, and this is unfortunate, and this is brand new, and you and I did not do a podcast on this, and I'm not going to belabor the point because it's not the greatest news in the world, even though it's not the longest amount of time, it is still considered what we call statistically significant from peer-reviewed literature. I am a patient advocate of the Celiac Disease Foundation. A group funds research. They funded research of a very young, intelligent celiac disease researcher, and he identified in a massive study that there is an increase in mortality. So there's an increase in all-cause mortality. There's a shortening of life. When I was first looking at some data sets, going back into graduate school, I was seeing like a shaving off of around 2 years for the celiac disease individual versus the non-celiac counterpart. And I know that there's so many things that live inside that sentence, but that's still a lot of time, right? When one loves life. So this researcher recently identified that we still have that problem, and we need to do everything we can to mitigate that and try to get more information and more understanding of why that is the case. You and I talk about separate episodes of these sound bites on our podcast, from everything from why vaccines don't work in the celiac disease population. So it's so multifactorial that it'll take a very long time before we get all the other information. And in that same number 3, I would categorize body changes, right? We did podcasts on changes in white matter and gray matter, and my whole world is my brain. So I do so many things to exercise my brain so that I can keep it functioning at a high level, where just having celiac disease and even being treated is associated with some degradation in brain function. And then lastly, there's a pretty big increase in cardiovascular disease and intestinal cancers for individuals that are diagnosed with celiac disease or undiagnosed with celiac disease. So very important for that number 3. Finally, number 4, and this is why I'm never going to stop doing this, and I hope it turns into a telethon, is number 4 is what really changed my absolute professional and academic career, and it was the lack of full physician awareness to celiac disease, how to make the diagnosis. And you know, Lexi, when you read a lot of papers, and you know I have a pretty darn good memory when it comes to scientific papers. I actually shocked myself that I had just a ton of data I was sitting on from years back, but I didn't live here yet. So I was looking at a ton of data on gastroenterologists from Southern California, where I now reside, and they really did not do well understanding celiac disease in a study that was done quizzing them and actually used controlled cases. There was actually 2,440 cases. And they just took a whole bunch of physicians from Southern California, using a database of patients that were active and physicians that were known to hopefully be able to treat it. And they found that only 32% of the doctors questioned were aware that celiac disease could present with symptoms in adulthood. So that's a very frightening sentence. 44% of responders, physician responders to this very academic survey, understood a certain blood marker that could lead to a diagnosis in certain circumstances. It's known as an anti-endomysial antibody. And it's something we've talked about on a previous program. I've written about it on how to get diagnosed with celiac disease. It's a highly used marker, particularly in pediatrics, because it's so sensitive in some cases. But imagine 4% did not know that. There's also probably one of the most shocking is responders, physician responders, did not fully know all the symptoms. And some really important ones, like they had no idea that abdominal pain could be a symptom of celiac disease, because they're like, well, it's too low. So it has to be like lower gastric pain, or all these types of arthralgias and joint pains and seizure disorders, and in women, unexplained fertility issues and lymphomas, all these other types of weird symptom complexes, just that have been published, by the way, not ends of one, like really big cases. Like we did a whole show on a failed vaccine trial that showed us that there's 2 new immediate symptoms that doctors need to be aware of. So it really was number 4 is lack of full physician awareness of seeing the warning signs and helping expedite to diagnosis.
And I think that one is really important because me personally, when I was going through the celiac disease diagnosis pathway that you recommended, when I went to my physician to say, I want to be tested for celiac disease, it was, well, do you have gastrointestinal issues? Are you bloated? And that was, if I had said no, she would have said, okay, that's fine. But I pushed for my own health. I was an advocate for my own health and said, no, I still want to be tested, and went through the proper testing regimen, and thankfully came back negative. For now, I am positive for one of the genes. But for me right now, it's just a gluten intolerance. And I know with a lot of the clients that I work with, when I ask them to go get tested, it's the exact same thing with their family doctor is, do you have gastrointestinal issues? I really don't think we need to test you. And that needs to change.
Yeah, it desperately needs to change. And again, let me please make this really clear for our listeners. I started showing up in doctors' offices presenting with cardiovascular abnormalities and incredibly accelerated resting heart rate with arrhythmias. This was verified in multiple day Holter monitors where you wear basically like an EKG device that records the data, and then you go back to the physician's office, but it also can read in real time now. We didn't have that back in the days when I was a kid. So then they would download my data and be like, oh my God, like I remember being told I was in AFib every minute. Can you imagine that? There's like a 75% increased risk for stroke. Like my wife says I had like 9 lives and so many guardian angels. Seizure disorders, then out of nowhere, I started having grand mal seizure disorders and different types of undiagnosed seizures that nobody could put a finger on. So as you can imagine, that was extremely disrupting to just the normalcy of life. You know, driving becomes just like almost impossible, or going to catch a subway, you know, to travel into New York City was a challenge because there's that extreme risk for having a seizure and falling and getting extremely hurt. It's a very hard way to have a childhood. Having said that, you know, I see this as a gift, and that's why I'm not going to stop this call to arms. And I'm glad you brought that up. I'm sad that you did, but I'm glad you brought that up because I also don't want to think anyone thinking I'm just picking on like this one study that was done that covered some doctors in Southern California. I've been studying Sultan, Charabadi, Zipser, Asiri, and McCormick. I actually had a nice long email exchange back and forth with Dr. McCormick, who was out of Georgetown at the time. But she published probably every one of the names I said are separate researchers that did statistical analyses on the knowledge of diagnosing physicians, including gastroenterologists, who should be the primary defense mechanism for catching this.
They should be the experts.
They should be the experts, actually missing it. And McCormick's was the most eye-opening, and it's why I reached out to her. Lovely physician, brilliant, and just a lovely, kind person to give me the time. And when I told her what I was doing, she was like, right on. Like, how can I truncate the time to diagnosis to get an accurate diagnosis? What she did was she started a research project with some colleagues right after the American College of Gastroenterology published a whole ton of work on this is how you diagnose celiac disease at their like 2013 symposium. And then she gave this whole massive survey to those physicians, that group, and then published her data as a poster presentation at the following year. And the data was like absolutely mind-blowing how many doctors were not aware of the signs, the full symptomatology, how it can present, how it presents completely differently in the pediatric population, various blood tests, the deficiencies of secretory monoglobulin IgA, how there's a 15-fold increase in that. And I know I'm getting a little technical here, and I apologize. Hopefully, I'm acting as fodder for your minds to go back to listen to some of our older podcasts or read some of my blogs where I really explain all that terminology clearly.
So let's get into what celiac disease is, because a lot of people think, okay, it's a reaction to gluten, but they don't understand the severity of it.
Yeah, celiac disease is a genetic autoimmune disease that can affect people of all ages. It primarily starts its war in what's known as the small intestine, and particularly this area of the small intestine from the duodenum to the jejunum, which is the last part, the second to last part of the small intestine. It can impact the ileum a little bit, but the ileum usually survives and will start to take on some of the role of the first part of the small intestine known as the duodenum, which is really interesting. So in English, something that transpires is known as intestinal intestinal enteropathy, some swelling in the gastrointestinal tract that can lead to some destruction. We know from our clinical research over the years that it's directly caused by the permanent intolerance to two proteins that are found in what we know as gluten-containing grains. Those proteins are known as gliadin and glutenin. The most common and harmful one for celiac disease patients is gliadin. That's how we've even developed tests for it over the years. An older test was known as an anti-gliadin antibody to see if you were actually making proteins against that. Now we know that's really not a great test. It's not as sensitive or specific, but it really was a movement towards getting some type of data. Now we have so much more armory at getting a proper diagnosis. And just so everybody would know, because believe it or not, Lexi, this is something I was asked after all our podcasts. But isn't spelt doesn't contain gluten? And I'm like, hold on a second. Spelt absolutely is a gluten-containing grain. So I think I should make this even more simple and say the gluten-containing grains, and there's a whole bunch of children coming from what I'm about to mention, but there's barley, there's rye, there's wheat, there's spelt, there's triticale, there's einkorn, there's farro, there's kamut. And those are more of the ancient grains that I mentioned that are really before the zombie apocalypse hit and people were dining out in beautiful restaurants, including when I was in Toronto in Canada, Lexi, in your neck of the woods there. There was like, ooh, tonight we're having farro, with our Dover sole. And I'm like, no, thank you, please. Because that's just a nasty older version of wheat, which is pretty rich in gluten.
And I do want to jump in here too, because a lot of people don't understand what wheat goes into. So the most common form of gluten that is out there, you've got your cookies, you have your bread, you have pasta. Anything that is based with wheat flour is going to contain gluten. So all of those delicious good treats, buns, like there's alternatives out there that are gluten-free, but it's something that in the standard American diet is so common. Fast food is loaded with it.
Yeah, it's omnipresent. You'll find it in spices. You'll find it in seasonings. It's a great cheap thickener. We started the monocrops that were so fascinating, and how wheat changed over the years and how it took on and was crossbred so that it would be softer, and some versions would be harder. Some versions would work better in bread. They're all just versions of this gluten containing grain family that results in the pathology that is known as this genetic autoimmune disease, celiac disease, that while the gastrointestinal tract is a primary site of attack, I want everyone to close their eyes for a minute and think of when a doctor is making the unfortunate diagnosis of cancer. They'll find the site of cancer, but then they want to know, was that the originating site? Or is it possible that it's spread to this location known as a metastasis? With celiac disease, it's linked to direct intestinal damage, which not only would be the destruction of the villi and the microvilli where we absorb our nutrients and digest appropriately, but it can lead to small intestinal cancers, large intestinal cancers, stomach cancer, but outside that area is where it can also just wreak havoc. And it's where you'll have people show up to their doctor with, oh God, I had a case 20 years of thyroid abnormalities, an autoimmune thyroid disease known as Hashimoto's thyroiditis. And I say, hey, you were never tested for celiac disease. And I start going through the odd symptoms. And of course, everyone was a checkoff. And I would have tested them just on the diagnosis of Hashimoto's, just to show you how confident I am in it. But sure enough, that was it. That was the disease. So it can happen outside the body. It's really amazing how people can still function when they're having their disease attacked autoimmune wise.
The body is incredibly adaptive and responsive and just wants to keep you alive.
It was the last set of symptoms that I had myself. It was just so remarkable. It was just the last set of symptoms. And that's when the levee broke. And maybe that was the best sign that I was finally able to get a diagnosis and a biopsy done.
Now, when did celiac disease become aware to the medical community? Like, what is its history? This is something we haven't really talked about, but, is it something that's fairly new? Have people been reacting to gluten since the Stone Age and people have been documenting it? When did it come onto the radar?
That is such a cool question. And it was something that I was so passionate about. I wrote a bit about it academically, and I'll be very brief because I just think it's so cool that there were breadcrumbs everywhere, pun intended. The first was actually this Artaeus of Cappadocia was the 1st century Greek physician. And he actually wrote in his works, in his writings, of something called the celiac affection. And he named it after a Greek word for abdomen, this condition. He was calling it like kiliokos, for kind of bastardizing the Greek word for abdomen. But that's basically what he called the condition at that time. And he actually wrote in his notes that if the stomach becomes irretentive of food and it passes through undigested, crude, and nothing ascends into the body, we call that condition Celiac. So I'll never forget that little quote that he had, and it was in his writings. He was very, very well respected physician, and that was the first time that I ever heard about it on the radar. So can you imagine that, like first century? And then in the early 19th century, there was a physician named Matthew Bailey, and he wrote of observations of a really severe gastrointestinal disorder that presented with chronic diarrhea, and it was caused by causing malnutrition in patients. And I can't even imagine how they diagnosed malnutrition back then. But nonetheless, he made that diagnosis. And then check this out. He was such a wicked smart guy. He prescribed nothing but rice, and he was curing these people. So that's the early 19th century. There was a physician.
In the 19th century, rice would not be cross-contaminated with other gluten things because there were none of these massive production facilities.
No, you really would have such a low margin for error. You're so correct. That was a great, very observant point. And that's really where things got completely nuts, was with agribusiness. In 1888, there was an English physician named Samuel Gee, and he actually describes that to his medical students that could be completely cured by removing wheat and other gluten-containing grains. They really didn't even know what gluten was. So he just removed what was predominantly consumed. People were still making bread out of wheat. It would rise. It wasn't like rice. So that was the predominant food source, and it was cheaper. There was a doctor named Sidney Haas in 1924, and he treated 8 pediatric cases of celiac disease. I love this one. With a banana diet, and he eliminated grain potatoes. So he was really trying. Again, we didn't really know what gluten was back then. So he was like, it's got to be those damn potatoes. They went out. All grains went out, blamed rice. He just fed these kids bananas, and he was putting these kids into remission. There was Dickey, who was a Dutch physician that actually found wheat was absolutely the primary culprit. And check this out. This is around World War II. He made the hypothesis in the Netherlands when there was food at the time. So there's a lack of bread during World War II in the Netherlands, and these children that he was treating for all these gastrointestinal problems and big bloated abdomens were miraculously getting better. And then when the Allied planes started dropping bread into the area, all their symptoms came back. So it was like cause and effect. This has to be it. And then in the 50s, there was the first technology to actually do a biopsy. So that was huge, that the first apparatus was designed and developed back then. So if it wasn't for those doctors, I never would have got my diagnosis. In the 60s, there was a common understanding that grain, starch, and eventually gluten was the problem. So we were getting closer to the year of my birth, and still all the doctors missed it. They were able to identify what was known as mucosal lesions because now they had biopsy tools. In 64, a doctor named Berger made the actual appearance of what was called anti-gluten antibodies testing. So that's very, very old form of testing in the blood of celiac disease patients. 65, Schuster and Marks came up with the connection between dermatitis and pediformis. We did a whole podcast on that skin disorder that was linked to it. 71, there was Shi and colleagues who actually discovered autoantibodies called reticulins that were associated with people with autoimmune diseases and celiac disease. Nobody does that test. It was just something in the old days, but it was a cool way to observe, hey, wait a minute. This is not just a gastrointestinal thing. Why am I finding these blood markers that's like something you would find in destroyed tissues? Reticulin is a term given to a collagen-containing tissue that you would find in autoimmunity. So holy crap, he's saying this is outside the gut. For back then and even to this day, we call mouth to anus outside the body because it has to be digested and processed and disseminated in certain ways. Even if you absorb it directly, it goes through some portal system like a lacteal, taking fat into the lymphatic system, etc. And then really briefly in summarizing, in the 80s, research started really connecting gluten to celiac diseases and other diseases like Down syndrome. The first connection was made between Down's and celiac, and then type 1 diabetes. There's diagnostic criteria that was adopted by the medical community back then, and they actually found out that a biopsy could diagnose 95% of people that had that disease. In the 90s, that's when there actually was the connection when we started doing genes in the 90s, to show you how far ago that was, we identified the genetic markers known as HLA-DQ2 and DQ8. So that's really the whole story. And then over the years, we just got more refined in each test, and it's continuing to this day.
Now, when did celiac disease become an official like medical diagnosis of this is celiac disease, this is what we're calling it?
Definitely the late 1980s. Definitely the late 1980s. They were positive that this is celiac disease, this is caused by gluten, and we can do a biopsy that can verify this diagnosis. Everything was complete speculation and conjecture and N of ones and really beautiful case histories of like 10 and 8 people. And I can't even imagine how much suffering went on, because I was looking at data sets of just some people just doing random tests. Like someone said, oh, well, these veterans donated their blood 50 years ago. Can I have access to that blood to do my research project? And this one group said, sure. So the doctors, they just did one blood test that you would normally do that doesn't even catch every celiac disease patient, known as an anti-tissue transglutaminase. And if you have a tissue transglutaminase antibody in your blood, it's a really strong indicator that there's something wrong, particularly with gluten, of course. And they were able to identify 1,500 cases of people long gone. Yeah, just looking at a real huge data set. And that's just this one tiny thing. And I can't help but think, oh my God, that's a shot in the dark. Obviously, the quality of the blood samples, the storage, how many of them had secretory immunoglobulin IgA deficiencies. And then I was interested in cross-referencing the diagnoses versus what did the individuals pass from. So there's still data that is being looked at from older samples that are still helping us to this day.
So it's not a new disease. It's been around for a very long time.
Yes.
And with those early researchers that reported the bloated stomach and the diarrhea and the undigested food, I guess that's where a lot of the physicians are getting that tunnel vision of this is what it is. But let's talk about some of the other symptoms. I know we've covered a lot of them in depth in other podcasts, but things that people don't know that they should be looking out for.
Yeah, and we should cover those most important ones and skip over the stomach ones, because any gastrointestinal complaint, I promise you, is directly, if there's celiac disease would be behind it. So it's not even worth mentioning it, I guess, right? Constipation, diarrhea, reflux, all of that. But hair loss, known as alopecia, especially if it's in one location or it's your full body, alopecia totalis, that's an autoimmune induced hair loss. Pausing of menstruation, known as amenorrhea, or cessation of menstruation, known as amenorrhea, symptom of celiac disease. Aphthostomatitis, which we know as canker sores, are associated with it. Ataxia, which is a form of balance and dizziness. There's cognitive impairment, where you have difficulty thinking and trying to figure out things at too young of an age. You can have delayed onset of puberty. You can even have a delay in your period. Definitely dental enamel defects. We talked about that. Depression, just having refractory depression is a sign. Malnutrition would be the cause behind that, as well as inflammation and disruption of how you make neurotransmitters, the gut-brain axis. We did a whole podcast on that. Headaches, chronic migraines, fertility problems, having a deficiency of various white blood cells or immune system markers. Medical doctors call that hyposplenia, because your spleen is where you mature white blood cells into the rogue weaponry that we need to protect us. Believe it or not, and this made many diagnostic lists checkbox by physicians knowledgeable in celiac disease and researchers such as myself, irritability is a sign. I know everybody right now is going, oh my God, do I have celiac disease? Elevations of liver enzymes. You can have nutritional deficiencies that doctors can't figure out. You could be obese. That's another important one. And we did a whole talk on that. And of course, my writing on that. Early onset osteoporosis, osteopenia, peripheral neuropathy, pancreatitis, pulmonary hemosiderosis is an inflammation problem within the lungs. Seizure disorders, thyroid disorders, urinary stone diseases, which means chronic kidney stones and doctors can't fix you. Refractory everything. My doctor prescribed this thyroid medication. It's not working. My doctor gave me this blood pressure lowering. refractory anything. So if you are refractory, means you're not responding to medical treatment and a real powerful, aggressive medical treatment. So let's say you have high blood pressure and our doctor's giving you medication, and then adds another medication and a fourth medication and nothing's working. You could have celiac disease and you're malabsorbing those meds. Or you could have refractory vitamin D deficiency, which is extremely common in celiac disease, where your doctor diagnoses vitamin D deficiency, but nothing you do is actually helping to repair it, even though you're taking a large dose of a patient on 50,000 international units daily, Lexi. And they were still at like an 11, where you really, that's a bad score in vitamin D world. You know, if you want me to give you the FDA score, it's if you're below 30, you have a problem. And I have higher grade markers, of course. I would love to see someone between 40 and 50 minimum. But when you see someone in the 11, wow, on 50,000 international units, classic celiac disease risk. And then weight gain or overweight. So those are some of the symptoms that are not really well known by doctors. What doctors are supposed to know, in addition to what we talked about, all abdominal stuff, is if someone has, you know, really bad edema, where they're swelling up and they look like they almost have malnutrition, which they call hypoproteinemia, which just basically means low protein. That's malabsorbing if the person's eating a bunch of their food. A severe itchy rash, even if it's not dermatitis herpetiformis. If your liver enzymes are increasing, you actually can become itchy. Floating stools. You may say, I don't have diarrhea, doctor. I go to the bathroom every day. Are your stools all greasy and floating up on top of the water? Not to be graphic, but it's important to know that that's a condition called steatorrhea. And, you know, then there's other conditions that are associated with the aforementioned Down syndrome, type 1 diabetes, Turner syndrome. There's just a whole host of conditions that doctors should be hitting on their checkbox. So I hope you can see, like, isn't it a great topic for a researcher or a scientist to sink their teeth into this disease? It is not this simple buzzword, I can't eat gluten and it only affects my stomach.
Yeah. And it can be any one of those symptoms. It doesn't have to be multiple. You can just have one. You can be obese and struggling to lose weight. You're trying everything and you're eating some gluten in your diet and that's what's preventing it.
And that's what's preventing it. And I'm covering, again, I just kind of rifled through just from memory. I mean, we do separate shows on all these things. We talked about lactose intolerances could be a risk sign for just having celiac disease. So it's so important that you really are aware and taking note of all the various symptoms. And again, I write about this. So I wrote a blog article about how I call celiac disease the clinical chameleon because it can mimic so many things. Please read that blog article because I think it'll really open your eyes and hopefully open your physician's eyes up to it. I got a lot of actual virtual pats on the back of doctors from other countries, doctors in other states, just saying, thank you so much. You know, I really appreciate this. And now I'm more vigilant and looking at the literature on this condition. So I feel like I did my job that day.
And in any of these symptoms, really, when those villi are damaged and they're unable to absorb things, that can be causing a slew of issues. Yes. So how does gluten harm the villi and like break them down so that they're not there?
Yeah, it's wild. And I'll be very brief, I promise. And I do write about this on the website on blogs that I've done. But let's just say a patient with celiac disease and undiagnosed celiac disease or current celiac disease consumes gluten. What happens? It enters this area called the submucosa in that first part of the small intestine called the duodenum. And that results in the production of autoantibodies to something called tissue transglutaminase. And that happens prior to gluten being broken down. So this substance found in gluten is not fully being deaminated, unfolded. There's problems with its digestion, and there comes this all-out autoimmunity against self-tissue caused by the gluten molecule. And this changes the charge and form of the gluten molecule. Think about that. So your own immune system, if you're undiagnosed, or you have my disease, you're actually changing the form and the structure of the gluten molecule and the charge with your own immune system. And that signals this autoimmune attack. And it fosters the binding of gluten to these very critical genes known as human leukocytic antigen genes, the HLA categories. And specifically, it's the categories known as HLA-DQ2 and DQ8 receptors. And then that starts something we're all talking about now in the news, a cytokine type of storm that's pro-inflammatory. Cytokines are communication systems. They're like a language to get the immune system to just whip butt. And that includes things like interferon gamma, and they're all secreted into the location. Then there's a lymphocyte presence, which are white blood cells that are specifically, literally marked with a cross for gliadin, the fragment of gluten, the main protein found in gluten-containing grains. And it starts an all-out war of what's known as CD4 T cells. All of that I just said results in the following simple statement. All of that results in a full atrophy and attack of the villi and microvilli within the duodenal area of the small intestine.
So your body is essentially breaking down its own villi.
Yeah, and then that causes the separation of the cells. They're known as intestinal tight junction cells, and they should be stuck together like laying a deck of cards out on the table to do a magic trick really tightly. But those start to separate, and that gets a porthole to open to allow this immunology, because that's what it really is. It's this antigen-antibody complex, the bad substance with your immune system saying, get them. And that lets that out into your circulation, and who knows where that will land. And that's really where the work is where will that end up going, right? It can affect people in so many different ways. Brains, various glands and organ systems outside of the intestinal lumen. But let me make this clear. While your intestinal lumen is still being destroyed. I was about to say I was lucky, but it took me so long to get a diagnosis. I got to the point, Lexi, where I couldn't dissolve an aspirin. I couldn't just get a regular aspirin, not enteric-coated. I couldn't get a regular aspirin to just dissolve. It started with a multivitamin that doctors, well, you just need a multivitamin. I couldn't dissolve that. And pardon me, the slang term back then was called fecal bullets. If you were given something to swallow and it didn't dissolve and it appeared in your stool completely unharmed, they basically called that bullets in the stool. And so I was losing medicine like that all the time, which required very, very high dose medications, novel ways of delivery. No one thought, let's look in there and find out why this is not happening. And then I finally hit the wall, and it was like kind of like the dam broke, so to speak. And then all the gastrointestinal symptoms you could imagine and discuss, I had all of them. And I had all of them, it seemed like almost overnight. And that was just an impossibility. And that was what finally led to breaking my case wide open.
And before that, you were on a ton of different medications for refractory conditions where doctors were like, let's treat it, try this, and nothing was working.
Nothing was working. Fun fact, I don't know if I mentioned this on a prior podcast, but when I finally got this diagnosis, I was still on those meds because they were considered life-saving. You know, atrial fibrillation is something you don't fool around with, and ventricular tachycardia, sinus tachycardia, seizure disorder. So when I finally got diagnosed and I started applying the principles, there's only one treatment for celiac disease right now. And that is a very strict, militant, 100% gluten-free diet for the rest of your life. And when I adopted those principles, in a pretty short period of time, I started hyper-absorbing the medication. So sadly, that also put me in the emergency room as potentially overdosing on cardiovascular drugs. So I went from like having a resting heart rate at my worst, my resting heart rate was around 211. And I know you're extremely fit. Can you imagine?
Like, oh my God, that's more than my heart beating out of my chest at my maximum exertion.
I would walk around 4 feet and pass out. It's really, I'm knocking on wood here because with all my knowledge in science, and we're staring at some degrees back there, I'm still really superstitious because I don't know how I walked away from that. I basically, in the movies, walked out of an exploding building, slow motion, unharmed, so to speak. So I had my heart rate go from let's say when at my better years, I was around 170 resting. And then I went right down into the upper 60s and then to 40s. And I was almost bradycardiac. I was bradycardiac by that point, below 50. And that was not good. And my blood pressure bottomed out and because I was over medicated. So I'm happy to report I'm on no medication. So if anyone's worried, thank you. But I'm on medication and I haven't been on any medications whatsoever since the age of 21 years. Hopefully celiac disease was behind my ill health.
So if someone is looking to get diagnosed, we did a whole episode on this, but as a summary, where should they start?
Yeah, I think, and I'm sorry that this is going to be a plug, but it's a plug of knowledge. And it's a plug that I gave away to the world because it's what I do for a living and I want everybody to know it. So here in the United States, we have these American Gastroenterology Association path to serology to a biopsy that could even include some genetics. I write all about that. So believe it or not, let me speed this whole process up. Instead of you finding a knowledgeable doctor, please read my blog article, What to Do If You Think You Might Have Celiac Disease, and just print it out and give it to your physician. And I take emails from physicians all the time. I actually had a patient read my blog, like we asked, and then go to their doctor, and the doctor reached out to me and said, so wait a minute, can I do a secretory immunoglobulin IgA along with the tissue transglutaminase? And I said, sure. Then we would know right on the spot. If the tissue transglutaminase is completely normal and their SIgA is absolutely within range for their age, fantastic. If it's sub-range for their age, we're going to flip the switch, and you're going to call the patient and say, here's the deal. Based on the value, we're going to shut you over to another line of testing. We might do tissue transglutaminase immunoglobulin IgGs. We might do gliadin deaminated antibody IgG serum if you're really low and you're like clinically deficient, or we might do different tests completely. We might do gliadin deaminated antibodies, IgA and IgG if your score is not deficient, but it's low for your age. So that's a lot of complicated stuff. Print the article, bring it to your doctor, and they will be able to follow this formatted path of what they should do. If you're currently following a militant gluten-free diet and you feel better like Lexi does, I do not want you to be sick. I still would ask you to read that article. Also read the Clinical Chameleon article, see if any of these symptoms matched your prior symptoms, and then ask your doctor for genetic testing. You want to know why? Because if you don't have the genes, you can't have the disease. So that's just cool to know. And it would be really neat that if you were like, oh, well, okay, well, I can never get this. Correct. You could never get it. And you might just have something known as an intolerance or a sensitivity to gluten. I'm definitely not going to deny that you react to gluten negatively, but you just will know right off the bat you don't have the disease, because around 30% of the non-celiac disease population will carry one of the genes, HLA-DQ2.5 or DQ8.
Such as myself.
Such as yourself. Yeah. Now, could you, in theory, on the spot, doing this podcast, I was going to say live, but you know what I mean, we're live. Could you go on to develop that if you developed really bad eating habits and said, I'm going to live on funnel cakes from here on, and I'm going to purposely go out of my way to buy Vital Wheat gluten and take it as my new protein powder? There's a chance. I mean, anything's a chance, right? That's why we have the genetic testing. You have a slight increased chance versus the classic dialogue they teach us 1 out of 100. Yours is like 3% versus 1%, right?
Yeah. And another thing, I found out that I had the one gene just through my 23andMe genetics. I was really curious about a whole bunch of different things, and that was the one that got flagged saying, hey, you have a gene for celiac disease. And that's what started my pathway to making sure if I was diagnosed or if I was in the clear. And thankfully for now, I'm still good.
Yeah, you're great. And you follow such a healthy diet. And if you just have a sensitivity, you can have moderation, like you talk about so often, and you're so honest about that. And I applaud that and I appreciate it, that you'll do this and this is the symptom that transpires and that stops. Clearly, listening to my story, moderation was not a factor. It was nowhere within the realm. And as everybody could probably imagine, absence makes the immune system grow fonder and more vigilant. So wow, you should see what happens if there's a breadcrumb that gets in my mouth now. It's like, I'm just done. I'm like updating my will. I'm teasing. Pardon my sense of humor. If you guys knew my real health history and you could have ability to watch that in film, you'd feel bad for me. But I don't feel bad for me because I use it really. It empowered me and it made me who I am. But my sense of humor is what makes me get through it all. But yeah, it's the main decision I made, other than following the research, why my daughter's never consumed gluten. And I've had people where I've made the diagnosis in them and they've said to me, oh man, but my daughter doesn't have celiac disease. I have celiac disease, but I'm giving this to her. I'm giving that to her. And that's not the decision we made in my home, because the longer I keep her away from it, there's a great chance she may never turn on those genes when she's living her own life, making her own decisions.
And let's touch on those genes one more time, just for clarification's sake. You said they were HLA-DQ2 and HLA-DQ8.
Yeah, so thank you, and that is correct. And they picked up by Green and Cellier years ago. Dr. Green, Dr. Peter Green, I've talked about him in the past. When I did a Reddit on celiac disease, I mentioned him. He's been a colleague, someone I really care about, and we're both do work for the Celiac Disease Foundation, where I'm a patient advocate, and he's on the medical board. And Dr. Green and Cellier said they just did a whole bunch of work talking about these different HLA types. And there are some subtypes, and I don't want to confuse anybody. All you have to do is remember, and you talk to your doctor, DQ2, and it's now DQ2 2.5, and DQ8. If you just know that and remember that, the lab tests will actually show you the subtypes, which are known as DQA105, DQB102. That's just going to pop up on a test. And then of course for the 8-1, there's other subtypes, which is O3 and 0302. So those you just have to remember those two pieces. Now I know what people are thinking, and I answer it all the time, and I even did it in an academic laboratory environment. Are there genes that are non-HLA pathways in celiac disease? Very strong potential, yes, and where it's not yet ready for prime time. I'm very aware of a study in 2016 by Sharma and colleagues. I'm aware he looked at like 8,676 pediatric cases, and he found like 50 some odd genes. It was exactly 54 SNPs that were non-HLA. And they included all these wild polymorphisms of things like TAGAP and various interleukins. We talked about interleukins in the past, Lexi, so I found that very interesting. And after our podcast, I went back to that paper, and it was interleukin 18R1 gene. So anyway, there's other genes that are being researched. Are those diagnostic? No. What was pretty cool about them is they were unique genes to pediatric community versus adults. It is not yet ready for prime time. I did a statistical analysis on the data. It's known as a Bonferroni correct significance threshold in statistics. If anyone's a stat major out there, thumbs up. And when I ran that analysis, there definitely was no threshold that reached the entire discovered SNP data set. So, and that SNP means single nucleotide polymorphism, the expression of the gene. So it's not fully right there yet, but I want everyone to know I'm on top of it. My foundation's on top of it, and we're waiting to see new developments.
Awesome. And I want to bring up the work that you did, I think it was last year, with your clinical support decision for diagnosing celiac disease. Can you just talk a little bit more about that so that if people want to get diagnosed, they can bring that to their physician's attention?
Yeah, I appreciate that. Yeah, so I worked for years I developed what's known as a clinical decision support system. It's kind of like a really interesting form of artificial intelligence that helps very knowledgeable individuals make the correct, as best as you could make it, fail-proof decision at any given moment across the path and the spectrum towards the diagnosis or not diagnosis for celiac disease. So getting them in the system or getting them out of the system for diagnosis, I felt that was lacking. I didn't have to look that far. I already talked about Ansiri and McCormick and Zipser, all of those amazing researchers, and I'm leaving out about 10 different people, and I thanked all of them. All of that amazing research led up to me going in there, well, how can I make the ultimate medical diagnostic brain, where if you just give it a little bit of information, it'll ask a subset of questions, and then that constantly leads the path to making perfect decisions. So I designed that system. I had unbelievable support of the community at Rutgers. I had unbelievable support at the Mayo Clinic and multiple universities, Boston Medical. I had physicians from the top universities in the United States. And it was overwhelming response and kindness, and everybody working hard to make sure that this project would see the light. It was an 18-month work of love. And finally was published electronically for the first time in the American Journal of Clinical Nutrition in May of last year, and then formally in the actual hard copy, it was November 2019. And it was awesome. It was 100% accurate in individuals obtaining a diagnosis and physicians using the system. I'm actually working behind the scenes with my very busy schedule with the government on a grant to develop this further and have this become a normal part of technology within the everyday electronic healthcare system. Thank you for even mentioning it. I didn't even think to discuss it. It really was a labor of love, and all I want to do is save anyone who has this disease from not getting a diagnosis and getting them diagnosed so they can go on and have a better life.
And we will include a link to that so that you can share it with your physician in the show notes, along with everything that was discussed today. So to recap, Dr. Pastore, what are kind of your closing thoughts for Celiac Disease Awareness Month in 2020?
Yeah, don't think your doctor knows everything, and they're wonderful people. And I don't mean that in a derogatory way. I don't think I know everything. And that's why I constantly study. And I have to get so many continuing medical education credits all the time to keep my certifications. So your doctors are humble. So please feel free to talk to them if you're concerned about this disease, and make them aware this month if you have a follow-up that, hey, I heard this podcast, or I had this one symptom that was mentioned. What's the harm of tagging on a blood work to your normal standardized blood work? And to find out exactly what that blood work should be, we'll make sure that there's links for that blog that I wrote, so that you'll be able to follow the right path. So please have an open and honest dialogue with your doctor, pretending they may not fully understand this condition, because this is the awareness month and we want to bring it to their attention. And also understand that 83% of people with this disease are not diagnosed yet. So that's why I can make that statement so boldly, is that your physician, and not all physicians are aware of this. They're still not fully aware, even though they're members of great groups. And it takes the Celiac Disease Foundation and their hard efforts and doctors that are involved with it to do everything we can to break down the walls of misinformation or lack of knowledge, so that we can all work peacefully to obtain a diagnosis for our patients.
So all of the links to previous podcasts that we've done, I think we've done over a dozen specifically on celiac disease and different topics around it. The articles that Dr. Pastore mentioned, they are all on his website, which is drrobertpastore.com. You can find him on social at Dr. Robert Pastore. And thank you guys so much for listening and tuning in every single week. We appreciate it more than you know. And just going to continue providing information around celiac disease and other topics as it comes out. So we'll see you next week for another episode.
Thank you so much for listening.